Hi, this is Dr. Brownrigg. If you're able to see this, obviously you've been able to download the required software and you have your firewalls turned off so that you can view this presentation, as well as you can download it to an MP4 player and play it off your iPads or any other MP4 player. So we're going to start with the Well Woman exam. And this is based upon the ACOG recommendations, which include that all women should have a periodic health assessment beginning at age 13. Regardless of their age, we want to start with the history, including their current health history, their nutrition, what are their current nutrition habits, and obviously if they've got a poor nutrition or poor diet, then you're going to be doing some counseling as far as how to improve their nutrition. You also want to know something about their physical activity. We'll talk more about amenorrhea associated with too much physical activity. Too little physical activity can also be a problem. Obviously, we want to know about sexual practices and their use of tobacco, alcohol, or any other drugs, which if you ask those questions correctly, and in a very non-threatening, non-judgmental way, most of your women will answer those truthfully. Of course, there will still be some who are kind of reluctant to share that information, especially if it is related to the drug use. So the health history, I want you to refer to your assessment book of choice. This is going to be fairly brief, and I'm not going into a full health history that you should be. When you're doing a health history, be sure that you're in a private area. There are some formats that you can choose. One is a self-administered questionnaire, which you have the woman fill out before you actually get into the exam room to meet with her. And there are some disadvantages and some advantages to the self-administered questionnaire. Obviously, a big advantage is going to be time savings. You can then follow up with verbal questions to verify the answers that the woman used or included in their self-administered questionnaire. So you can save time, but you still have to do that follow-up. Other advantages is that some persons, or one other advantage I should say, some persons may disclose information more freely if they're doing it in the self-administered questionnaire than if they're actually asked those direct, sensitive questions. So there are some benefits. Some disadvantages is that frequently the terms on those self-administered questionnaires are unfamiliar to the patient, so they either don't answer them or they don't answer them correctly. Questions may be misunderstood, or sometimes when we are doing the self-administered questionnaire, we're losing that nonverbal feedback. And of course, when we do a self-administered questionnaire, you are also the provider is going to follow up again with a visual and a verbal review. So there are advantages, disadvantages, and it's something for you to think about in your own practices. You want to know about the Well Woman exam, the HPV immunizations, and I think I gave you some references regarding HPV immunization and when it is ideal to do those immunizations and why it's ideal. There are two types. The Gardasil is effective against types 6, 11, 16, and 18 of the HPV virus. It's administered to girls 9 through 26 years of age, and we try to do that around age 11 and 12, that age that we're going to administer it and immunize young adolescents, teens, preteens, before they become sexually active, which is the ideal time for them to receive the immunization, because the immunization is going to help to prevent the infection, but once the infection is there, it's going to do nothing for those that are already established. Gardasil can also be administered to boys ages 9 to 26, and we want to administer that routinely between ages 9 to 11. Excuse me. The schedule for the Gardasil is going to be administered IM. They get the initial dose, the second dose in 2 months, and the third dose in 6 months. The other HPV vaccine is Cervarus, which is only effective for types 16 and 18. It's only right now approved for females ages 9 to 26. Again, we want to get them immunized before they're sexually active. And it's administered, again, 3 injections, but where the Gardasil was at the initial at now, and then the second one at 2 months, the third one at 6. The Cervarus varies a little bit, with the second dose being at 1 month instead of 2 months. Other immunizations include the hepatitis A and B, and measles, the Tdap, the annual influenza, and you want to get all of this information in their history. If they don't have any of these, then you want to check them, catch them up. Well woman exams should include sexually transmitted infection screening and discussion of contraception. It also should include a history regarding folate intake, especially those women who are planning to become pregnant. And we want to talk about their folate intake, as well as those that are going to want to become pregnant within the next 2 to 5 years. We want them to be taking that folate, and some sources actually say even before that 2 to 5 year range. During the well woman exam, we start talking about breast awareness, osteoporosis screening for women over age 65, and colorectal screening for women over age 50. We want to get their gynecologic history, which includes their menstrual history, their age of menarche, their last menstrual period, the length of their cycle, average number of days of their menses, characteristics of their menses, of their menstrual flow, regularity of their cycles, and description of any irregularities that they may have. Pregnancy history, infections, have they had any sexually transmitted infections? We want to know about any douching, gynecological surgical procedures that they may have had, their sexual practices, contraceptive use, and we also want to get an idea of any abnormal symptoms that they may have. And when we're asking about STIs or infections, we also want to know the type, treatments, if they've had any complications, if they've had HIV screening, and it's important to know their number of sexual partners. We will ask if they're currently sexually active, their use of condoms. It's also a good idea when we ask about sexually active in again, very non-threatening way. We ask men, women, or both, and we ask that question of the women as well as the men that we may be doing a physical exam on. Douching, frequency, solution used, and the reasons that they douche, because this will be maybe a good opportunity for some teaching. We want to discuss with our patients the symptoms and the signs of cervical cancer, including abnormal vaginal bleeding, which we'll talk about next week, any postcoital bleeding, vaginal discharge, and we want to find out more information, whether it's watery, mucoid, if it's purulent, or if there's an odor, especially if there's a bad odor. During the history of our patients during the well woman exam, we are very aware throughout this history. What we're finding out as far as cervical cancer risk factors is that the vast majority of cases are caused by persistent, now persistence is a key word, persistent high risk, which is the 16 and 18, HPV infection. We're going to ask about multiple partners because that's a cervical cancer risk factor. We're asking about their onset of sexual activity because the earlier the onset, the increased risk. Their history of sexually transmitted infection, history of smoking, and we also want to know more about their use of oral contraceptives because this actually is an increased risk for cervical cancer, and it's not well understood. It appears that the estrogenic effects of the oral contraceptives may prevent the ectopy of the cervix from receding into the cervical canal, and we'll look at some of that some pictures of that ectopy, which leaves this area, that transformation zone, vulnerable for a longer period of time. And that may be the cause. Another relationship, and again, this isn't understood, these are kind of educated guesses right now, is that a female who is using oral contraceptives may be less likely to use barrier protection, which increases their risk of contracting the HPV. So we don't know why the oral contraceptives, but those are two theories. Other conditions associated with the HPV includes the genital warts, the condylomata acuminata, cervical dysplasia, cervical cancer, and again, the high-risk HPV viruses are 16 and 18, which cause 70% of cervical cancer. Low risk is 6 and 11, although there's a tiny risk, but those are the viruses that are associated with the genital warts. And if you'll remember, the Gardasil protects against all four, and whereas the Cervarix protects against the high risk 16 and 18. Pregnancy history, we want to know their total number of pregnancies, which is the gravida, the number of term births, which is the term births between 37 and 42 weeks, preterm births, which are those that occur before the point of viability, abortions, which we want to know whether they're spontaneous and induced prior to 20 weeks, and then their living children. So we used to get their gravida and their para, and now it's a good idea to get more information, including the term births, the preterm births, and any spontaneous and induced abortions. So the physical exam for the well woman visit, we want, well, first, it's important to understand that this can vary and be determined by the organization in which you work. It can be determined, it can vary a little bit by location, and really what constitutes a complete well woman exam is not absolutely standardized at this time. You do want to evaluate the major organ systems briefly and carefully, but other than the reproductive system, you're not going to be as exhaustive in this exam as you might be in someone just coming in for a regular physical exam or a pre-op exam and that sort of thing. So in general, what you're going to be evaluating during your physical exam includes the height, weight, BMI, blood pressure. They should have an annual clinician breast exam by age 19, and I don't know that we're very good about doing that out in practice, but that is the recommendation. So they should have a breast exam. The well-woman exam includes the pelvic examination, which you're going to look at the external genitalia, the vaginal orifice, the accessory glands, and the femoral pulses. Then, of course, you're going to do the speculum exam, and for women ages 50 and older, the rectal exam. So the pelvic exam itself includes the external genitalia. We're going to inspect and palpate the accessory glands, the Skene's and the Bartholin's glands. Speculum exam, you are first going to have to choose between a metal versus a plastic. And this is very provider specific. I know most of the OBGYNs I know still prefer to use the old metal. I prefer to use the plastic because I like that internal light. So I think it's what we become most competent at using, and then that's what we tend to stay with. I would like to know more from Shauna to know which speculum she uses in her exams. Either way, and especially with the metal, you want to warm the speculum. If you're using the plastic speculum that has the internal light source, if you turn the light on a minute or two before you do the exam, then that plastic speculum has warmed itself up. Now, there's some controversy about whether or not we use gel on the speculum. And I was definitely taught you never use the gel. You can lubricate the speculum with some water. But now the evidence indicates that a small amount of gel on the speculum does not interfere with the cervical cytology, and it actually decreases the discomfort of the speculum insertion. And so at this point, I recommend that you use a small amount of gel and don't go overboard, just enough to make it easier to insert the speculum, and that will decrease the discomfort. Also, I've already talked about in the pelvic exam we're checking the accessory glands, the Skene's and the Bartholin's, and also you're always going to check the femoral pulses, as well as the femoral lymph nodes. Add that to your notes. Okay, when we do the speculum exam, we want to visualize the cervix. We're going to look at the color. We're going to look for any Nabothian cysts, which is actually normal. Any friable tissue that bleeds very easily on the cervix. Any granular areas, white patchy areas can look very suspicious. Discharge. And then for our specimen collection, we want to collect cervical cells for cytology, and then we want to get vaginal or endocervical sample for gonorrhea or chlamydia. And we also, if there's any suspicion, depending upon the discharge, vaginal secretions that we're going to look at under the microscope to determine whether it is consistent with bacterial vaginosis or chlamydia, Chlamydia is one of the things that we're going to be suspicious of with certain vaginal secretions, but the vaginal secretions for microscopy is going to be looking more for any candida yeast infection or for the bacterial vaginosis. So for collection, doing your speculum exam, it's pretty important to do this when the woman is not menstruating, so the recommended time is maybe a week before their period. You want to determine if any discharge is coming from the cervix or if it's coming from the vagina. Normally the discharge is going to be odorless. It's going to have a creamy or clear color, and be thin or thick depending on the time of the menstrual cycle. When we do the vaginal swabs for gonorrhea and chlamydia testing, that's going to be the vaginal secretions as well as some endocervical secretions. We can do that now along with sending in the Pap exam, but it's not considered as sensitive as if we use vaginal swabs and send it in for actual testing, then even if we are doing a full pelvic exam and doing the full Pap and sending the Pap in. So this is what the normal cervix looks like. The color should be pink. Notice that it's symmetric. In this particular case, you can see the cervical os is a slit, so that gives you some information that this cervical os is multiparous. This woman has been pregnant in the past. We're also wanting to look for the transformation zone. Now, the transformation zone is where the actual types of cells on the cervix change. And as a female gets older, this reddened area, I want to say those are the columnar cells, and it actually is going to recede or retreat into more the internal os or inside of the cervix, and it will get to a point, notice that it's obvious in this area, and then in this particular cervix it's retreating down, and we can just see a small amount of the glandular cells or the columnar cells, and then in this picture we can't see them at all. Now the reason I show this is that it's right at this transformation zone that is most likely to become dysplastic, or we start seeing the abnormal cells. And so it's at that transformation zone that we want to be sure when we're doing our Pap that we get those cells. And that's why we want to actually, if we can't see it, and even if we can, we want to get right inside the cervical os. We want cells from outside the cervical os, but we want them also from inside the cervical os to be sure that we're getting cells from that transformation zone. And if we don't have those cells, our report back from the path lab will actually tell us that those were missing. These are Nabothian cysts. Obviously, this is an artist graphic of them. I don't know that I've ever seen that many Nabothian cysts on a single cervix, but they're small, white or yellow. They're raised areas, and actually what they are normal variation, and they're retention cysts of the endocervical glands. So they're normal variation of no concern. That's compared to the cervical polyps, and a cervical polyp, notice that these are the polyps that are actually, we see them beginning up inside the cervical canal. Here we have the external os, and up here we have the internal os, but they're coming from the canal, and they're actually then, we see them on the exam as they have, this is the internal os and the external os, and here we see them receding down through the external os of the cervix. And this is an actual picture of, we see this good-sized polyp here. Those may interfere with normal menstruation if they get large enough and close off that external cervical os. Some people will leave them and watch them. Other people want to remove those. It depends upon what kind of symptoms the female is having. Okay, this is a picture of cervical cancer, and what they've done here is that with this being so white, they have actually applied a little bit of acetic acid. And with that acetic acid, which is vinegar, by the way, then it will change those abnormal cells and make them have a much more distinct appearance. This is usually done on colposcopy. So if we get abnormal cells and it is, if we're really getting abnormal cells, something beyond ascus, which we'll talk about in the PAP presentation, that if it is an abnormal cell, then we refer for colposcopy. Many women's health nurse practitioners do colposcopies, and I think some family nurse practitioners do. But it's a different procedure, and they go in and they will actually apply the acetic acid or the vinegar to the surface of the cervix, and then this area that shows up white is very suggestive of cervical cancer, and this is the area that they might do the LEAP procedure, or they would do the LEAP procedure to try to remove these particular cells, or that particular part of the cervix. So what are the screening guidelines for PAPS and cervical cancer? The screening guidelines have been identified by the American Cancer Society, the American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology. And those guidelines were released in 2012. The U.S. Preventive Services Task Force also released their new guidelines in 2012. And these guidelines are different. They've changed. The ACOG actually has their 2009 guidelines, but I've given you a link to an ACOG statement stating that they actually were a part of those 2012 screening guidelines with both the American Cancer Society group as well as the U.S. Preventive Services Task Force, that they were part of those discussions and part of the development of those guidelines. So actually ACOG, even though I'm going to show you the guidelines are a little bit different from their 2009 guidelines, they really have accepted the 2012 guidelines. In your required readings, I have included a PDF document from the CDC which outlines these guidelines. They're different. I'm finding that practitioners are very slow to accept the new guidelines, and you will go out into your practicum experiences and you're going to see a lot of practitioners still following the old guidelines. Now, this probably isn't because they are rejecting the new guidelines, but more often what we find and what students report back to me is that the practitioners are not aware of the new guidelines. So this may be an opportunity for you to help educate the practitioners that you're working with out in your practicum experience. And the reason it's important to even screen for cervical cancer is that it used to be the leading cause of cancer death for women in the United States, but in the last 40 years, the number of cases of cervical cancer and, more importantly, the number of deaths have really decreased. The decline is largely the result of women getting their Pap tests, which can find cervical precancer before it ever develops into a full cancer. In 2008, 12,000 or a little over 12,000 women were diagnosed with cervical cancer, and still in 2008, 4,008 women in the U.S. actually died from cervical cancer. So it's still a problem, and it's not something we slough off. Yet the reason we've had such a tremendous decrease in the incidence and the deaths from cervical cancer is directly related to the PAP screening. So here are the screening guidelines. Again, notice that ACOG is a little bit different, but very important, and this is different. We used to start doing PAP exams 3 years after a female became sexually active. So if they became sexually active at 12, it was recommended we do their first PAP exam, PAP test at 15. Now the recommendation is no screening. If they're under 21, we do not screen. The women aged 21 to 29, and again, because ACOG states that they embrace the new guidelines, we're really going to look at the Preventative Services Task Force guidelines and the American Cancer Society. Women aged 21 to 29, cytology every 3 years. And during that age group, you're going to see a lot of providers doing HPV testing in this age group, but it's not recommended. Now, women aged 30 to 65, the recommendation is cytology every 3 years, or cytology plus the HPV testing every 5 years. So if we don't do the HPV testing in the women 30 to 65, then the cytology should be every 3 years. But if we do the HPV testing, then it's the cytology every 5 years. And the American Cancer Society says that both are regardless of any screening history. The women over age 65, women over age 65, if they've been adequately screened in the past, the screening should be discontinued. And women with a total hysterectomy, no history of high-grade cervical endothelial neoplasm, we discontinue their screening. So the important pieces of these changes is that according to all of these groups, the first PAP test is at age 21, and we don't do them sooner than that. We test every 3 years until age 30. Age 30 or older, the HPV test with PAP test every 5 years. But if we can't do the HPV testing, then the PAP is going to be every 3 years. And the new recommendations state that no more testing after hysterectomy or age 65 unless they have had a previous positive PAP history. In other words, the belief is less is actually more as far as testing for the changes in the cervical cells. So what's the evidence for the new guidelines? Well, first of all, it's important to note that the yearly PAP interval was very arbitrarily chosen, and there was no evidence to do it yearly. So now we know that cervical cancer is a sexually transmitted infection caused by human papillomavirus, and that most HPV infections are cleared by the body's own immune system based upon studies that have been out for really a long time, 6, 7, 8 years. Most women, especially the younger the woman, the more likely their HPV infection is going to be cleared by the woman's own immune system. So what we're doing, the evidence for the new guidelines is based upon the likelihood of progression to cancer. Young women are going to clear the HPV better than the older women. The likelihood of progression to cancer is based upon the duration that the HPV virus remains, as well as any persistence of the infection. So by increasing this time between testing and not even doing the testing in our young women, we are allowing the young woman's immune system to take care of the problem by itself. But then after age 21, when we do the testing, if we have persistence of the problem, then we're going to be looking closer and treating accordingly. This is the natural history of the HPV infection, and it's pretty age-specific. Notice that HPV infection really rises, and it actually peaks up here around 19, 20 years of age, and then the rate of the HPV infection drops off. But the older the woman, the more likely we're going to find those precancer cells, and even then, the older the woman, the more likely we're going to find the cancer cells. So in this younger age group, they clear it themselves, and we're less likely to intervene with treatment during that age group. So the advantages of the new guidelines, they balance the benefits and the harms. The new guidelines avoid unnecessary emotional and physical trauma, especially for those young women less than age 21. And I showed you the picture of the cervical cancer and told you that's the area that they would go in and do the LEAP procedure to remove that tissue. But doing the LEAP procedures may increase the risk of preterm birth. So it's not without its possible risks. Other advantages of the new guidelines is that it quite honestly frees up time. If we're not doing the PAP, we have more time to discuss other important health issues with these women. And it allows us to make the clinic visit more efficient. It may actually increase clinic visits. I'm not sure that's true. I just think if women know that they're not having their annual PAP, I don't know that that particular benefit or advantage has actually been, we have good evidence for it. But if women know that they don't have to have that dreaded PAP exam, then it's believed that they may come in more often. And obviously it's got tremendous potential to decrease healthcare costs if we're not doing PAP tests annually that aren't necessary, and may lead to treatment that is not necessary. Exceptions. Now this is important. Exceptions to screening guidelines. They should have annual screening if the woman is immunocompromised in any way. If she has HIV infection, if she is a transplant recipient, if she's taking any types of corticosteroids, if she has a history of CIN 2, 3, or a history of cancer, and if she had exposure to DES in utero, which we're kind of getting beyond the point that that's going to be an issue, because it was in the 50s that women were actually exposed to DES in utero. So not many of those women are still within that PAP range, but at any rate, if there was exposure to DES in utero, then it's an exception to the screening guidelines, and we're going to screen at least annually. Non-exceptions to screening guidelines include early onset of sexual activity, sexual activity with multiple partners, or with a new sex partner, and tobacco use. These all used to be reasons that we would do annual screening because it put women at a higher risk, and we no longer consider those exceptions. So no longer if they have had an early onset of sexual activity, because by age, if they've had early onset at 13, by age 20, they've cleared it. And if they haven't cleared it at age 21, the whole progression of cancer from the HPV infection is really quite slow. And so we're going to catch that at a time that it is still safe for that female. Now, again, we are going to do annual screening if they're immunocompromised, transplant corticosteroids, CIN 2, 3 or cancer, and exposure to DES in utero. Get back where I'm supposed to be on my slides. Evidence for HPV co-testing. So when do we do the HPV co-testing? Before age 30, when we know there's a high prevalence of HPV, but we also know that this is the age group most likely to clear that HPV, we do not co-test. In women who are greater than or equal than 30, co-testing detects about 17 to 31% more precancer. And we also know that HPV testing is superior to just the cytology, looking at the cells, for detecting cervical adenocarcinoma, which cervical adenocarcinoma actually has a poorer prognosis, and unfortunately we're seeing a rise in that. Management of abnormal PAPs. Now, there is the guidelines for managing abnormal PAPs is pretty extensive. And I wish I could tell you what is going to show up on your certification exam. I suspect the certification exam won't go much beyond ASCUS or high-grade intraepithelial lesion or low-grade intraepithelial lesion. And so I'm not going to go over these. Instead, I've given you the link both here as well as in your in Blackboard to the consensus guidelines. And these are the guidelines. This is the link I've given you to. You can access the updated guidelines. There are algorithms available for you. The reason they changed it, I've also given you a, let's go back here, and I think I have it on this slide. Or maybe not. So let's, but I've given you a link to those actual guidelines for you to go in, download, have them available, and if you, and you should be using some type of mobile device in the clinical area, you can actually download the apps. So you can put into your iPad that this is their age, this is the result of their PAP, and it will take you right to the guideline that tells you what needs to be done to follow up on that particular woman. So, I told you that we no longer require the annual PAP exam, but that does not mean we're not going to do an annual well woman exam. This is really important because a lot of your patients are going to interpret, I don't have to have a PAP every year, so I don't have to come in. Wrong. It is still recommended they have their annual well woman exam. The Affordable Care Act, and some people call this the Obamacare, mandates coverage for at least one well woman preventative visit annually. And this includes basic medical care, the BMI, which is considered the new vital sign, and obesity counseling, cardiovascular and cancer screenings, mental health and substance use abuse issues, vaccines. So just by doing not doing the PAP does not mean that we're not going to do the well woman exam. Mandated coverage includes screening for gestational diabetes, lactation coverage, counseling, and support. It has included the requirement for adding the HPV test to the PAP for women who are greater than or equal age 30, and then a PAP every 3 to 5 years, depending upon whether or not they've had that HPV. This is important. Some insurances may not cover HPV for women less than 30. Mandated coverage includes annual counseling on sexually transmitted infections, counseling and screening for the HPV, screening and counseling for domestic violence, and patient education counseling and availability of full range of contraceptive counseling. So those are now mandated by the Affordable Care Act. I'm just going to do a brief, very, very, very brief, because you should have had this in your physical exam course, but talk about the bimanual exam. And I want to encourage and emphasize the bimanual exam should be done with the examiner standing, and the rectovaginal exam actually gives you a better evaluation of the uterus, the size of the uterus, as well as the position of the uterus. The pap smear itself, following the new guidelines, what we want to do with the pap smear is get a sample of the cervix cells from the transformation zone of the cervix, where we can use a spatula plus a cyto brush, or we can use, you see the spatula, way that's sensitive to this mouth. You can see the spatula here, and the spatula, you're going to get the pointer, your tip goes into the cervical os, and then you just rotate the spatula around about 3 times to be sure that you're getting the tissue from both inside that cervical os, trying to get to the transformation zone, as well as tissue on this side of it from outside the cervical os. And then if we're using the spatula, it is recommended that you use the cyto brush, and the cyto brush goes inside the cervical os with about a quarter to a half turn. So you're not going to, this can be very irritating and frequently causes bleeding. So this isn't going to be an aggressive exam, but again, we're trying to get into the cervical os and get that transformation zone, which is the zone where we're most likely going to see the cells start to become dysplastic and change. And then the cyto brush is on this side. So this is the brush, and it kind of combines the spatula and the cyto brush with the tip going inside the cervical os, and then the remainder of the broom is on the outside of the cervix, and you're going to circulate that broom in a circular motion to get those cells. Now there's two types of pap smears. There's the conventional or liquid-based, and the liquid-based, I haven't seen the conventional putting it on the slide for a long, long time. I think most practitioners are now using the liquid-based because third-party payers have now agreed to pay for it. So we have the two types, and the liquid-based tends to be, we really haven't found any true improvement or increase in the ability to find the cells, but most practitioners believe it's there. So what you're going to do, let's see if I have another slide here. Yeah, I do. With the pap smear, and notice we have the broom. You want to look inside the vagina, and then you're going to grasp the cervix with the speculum, and then you're going to open up that vagina so that you get a nice view of the cervix. You want to insert the bristle. You can't see that very well here, but it would be the central bristles of the broom into the endocervix, so right in here, very deep into the endocervix, and then allow the shorter bristles to brush the outside of the cervix here. You're going to gently push, very gently push, and rotate the broom in a clockwise direction. Then you're going to place that broom in your liquid solution, or the vial, and press firmly to the bottom of the vial so the bristles are actually forced apart. Swirl vigorously about 10 times to mix the specimen and the medium. Then you're going to remove and discard the broom. One thing, and I'm telling you this from bad experience, if you're using the liquid medium, be sure you check the expiration date, because if that liquid medium has outdated the lab, path lab won't even look at it. And you have to call your patient back and say, well, we have to redo that. And they're not very happy. So when we're doing a pap smear, we want to get the cervix, so the endocervical sample right here. And then the outside is the cervical sample. And then we also will want, especially the vaginal sample, if we're looking at secretions, if we're concerned about maybe there being a sexually transmitted infection, and we're going to send that to the lab as well. Okay, this ends this particular presentation, and we will follow this with the next presentation being PAP interpretation.